Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, everyone. This is Dr. Jill Jin, Senior Physician Advisor for AMA Steps Forward, and I am your host for today. Today on the podcast, we are joined by guest Dr. Topher Sharp, who is a practicing internist as well as the Chief Medical Information Officer at Stanford Medicine. Our topic is how Stanford created a personalized, multi-pronged EHR training approach for individual physicians and APPs. Dr. Sharp, welcome, and thank you for being with us. Can you start by telling our listeners a little about yourself and your background?
Jill, thanks so much for having me. I really appreciate this podcast and the work that you do with the AMA. I'm a practicing physician here at Stanford Medicine. I've been on faculty since I came here and finished my internship and residency and chief residency at Stanford. So at this point, I have a lot of cardinal imprints on me. But I started my work here as a clinician educator, really focused on clinical work and teaching for many years. But over that time, I started to see the power of what technology could bring into some of our work that we do clinically. And I became very interested, started to work on improvement using technologies, and ultimately now have really seen my career shift more towards this as the Chief Medical Information Officer here at Stanford. And in that role, really, I think of myself as having the responsibility to both make sure our technologies work for our clinical care, and also to make sure that our clinical caregivers understand how to leverage that technology to their very best to be able to care for their patients.
Well said. It goes both ways. So as we all know, the EHR is a huge time sink for physicians, and EHR-related inefficiencies and burdens are a major contributor to physician burnout. And we also know that much of this problem stems from how the EHR is set up at the organizational level. And we do have other podcasts addressing this. However, individual EHR optimization is also very important and something we haven't touched on too much on this podcast. So I'm very interested in hearing about this program that Stanford created for individualized and ongoing EHR training. So can you tell me more about, first, how did this idea come about? And second, how does it work?
As background, as you mentioned, I'm going to again reference back to this idea that it's not only about whether we build a good system, it's whether we actually have users that are competent, proficient, feel that they can use the system to their best advantage. And that makes a big impact on your day. And as you point out, we know and we really are very much aware that, physician wellness is in a crisis state. And we had the same phenomenon happening here, knowing that burnout leads to decreased professional satisfaction, reduction of clinical activity, members exiting the workforce, and lots of secondary effects on their personal lives. I hear directly from my colleagues when they tell me they're going home and reopening their laptops and sitting down to finish their work after they've put their kids to bed and had their evening dinner and done the other things that are so important for their wellness. And we know from good research that physicians spend twice as much of their day on the EHR as they actually do interacting with their patients, and that's a real problem. We think that's a problem that needs to be paid attention to. We also have come to see that education actually really matters, and there's published evidence that say physicians who agree that their organization does a great job with EHR training and support are twice as likely to report lower burnout scores compared to their colleagues. And I think that was a real kind of lesson for us to say, this may not be just enough to pay attention to the EHR itself. We really need to pay attention to the people who use it. I was also personally really inspired when I read the book by Daniel Pink called Drive. Daniel Pink talks about and shows a lot of evidence that motivation for skilled workers comes out of things like experiencing autonomy, mastery, and purpose. And I think as physicians, we have a great sense of purpose. But what we found was that our physicians who had a great sense of clinical mastery felt completely undercut when we brought them onto an EHR where they felt like novices. And we took away that sense of mastery when we put them on these EHRs. And we even for us, we thought, well, I'm sure they'll figure it out. They're smart people. We're sure they'll figure it out. And it turned out that for us in 2016, we were 8 years into our EHR journey, having implemented 8 years prior. And we still had calls every day about how dissatisfied our physicians in particular were, but our clinicians in general, in terms of their experience of the EHR. They just found it was hard, and it kept staying hard for them. So, with that in mind, we went back and said, gee, we've been doing this for a lot of years, but our users still don't feel comfortable. They still don't feel confident. We need to go out and help them. So the first thing we did was we set up some great communication material and education and tip sheets and all kinds of good things. And we thought, well, that'll be terrific, won't it? And it really fell like a lead balloon. So we said, well, we'll make classes and we'll invite our physicians back to the classroom where we'll help them, we'll teach them, we'll show them the latest tips and tricks. That was pretty poorly received as well. We had problems with enrollment because nobody wanted to spend another 2 hours of their evening coming into a classroom. No one was really excited about the EHR to begin with. And the idea that they would receive some generic training just didn't sound right. And so we went a step further. We said, well, we'll customize these classes to specific clinicians or specialties or clinics. And we tried that and it was better, but we still found that our clinicians had very different levels of comfort and they were at very different points in their own learning journey. And basically, some people would sit in the classroom and be bored out of their minds, and other people would be lost. We just found that that still wasn't meeting their needs. The need was so sophisticated and so individualized. And so that really gave birth to this idea that we needed to come back to a one-to-one model and meet physicians where they're at and clinicians where they're at in order to be able to uplift their abilities and their confidence in using these technologies.
Got it. Yeah. Well, much of what you said resonates so much with me about how when you just offer the tip sheets in classes and webinars or grand rounds, it's just one more thing to do. Investing extra time in order to be more efficient, even though it makes sense mathematically, just isn't something you want to do, at the end of the day.
We think that's totally right. And we moved to the hypothesis that we needed to go to them, not bring them to us. So, with that in mind, we made a micro investment back in 2016. We took all of 2 clinical personnel and we took them out of our normal training cycles and said, we're going to ask you to create a concierge program, a program that goes out one to one and really interacts differently. And let's see what happens. Let's build out a program. What would that look like? And we built out a program then that really is about personalized one-to-one coaching instead of training in a typical classroom and didactic setting. And our goal out of the gate was to improve EHR efficiency, to improve satisfaction with the EHR, and to lower burnout. This is not about getting more efficient. This is not about seeing one more patient. This is not explicitly about going home early. This is about feeling like you really feel confident, competent, and that you know what you're doing in your day, and that you feel more satisfied with that experience. And so we started with a couple of areas of focus, and I want to quickly say why here. I mean, first of all, we said we're going to go to physicians specifically. That's where we're going to start this program. And these were the loudest, most dissatisfied members of our organization. They're probably some of the busiest members of our organization. They're our most valuable asset, at risk to really wasting their time and what they can offer to patients. But we also realized they're the busiest and the hardest to reach. So if we're going to really reach this group, we're going to have to think differently. And we also started with a focus on ambulatory care. And there too, we said, well, why ambulatory? In ambulatory, a lot more of the practice model is a solo model. You're doing it yourself often. It's one doctor in a room with one patient. Where in the hospital setting, often you've got nurses and pharmacists and residents and all these other members of the care team interacting with you throughout the course of the day. And then one of the other aspects that we set out of the gate was we said, how are we going to have people engage in this program? And we had ideas like, well, we'll mandate it. How about that? We'll tell them that they have to do it because it'll be good for them. It'll be like medicine. We realized that actually mandating or blatantly making incentives around this might get the job done, but not bring what we really wanted to do, which was to up level and support our physicians instead of telling them that they're not good enough. So we made this a voluntary program. And one of the key metrics of this program has been enrollment or engagement from the start. It's a strictly voluntary program. And then we work with individual physicians, we work with physician leaders in clinics or other department settings, and we help them see the value so they can encourage their members along to join in and take advantage of the program. It's meant that we have to do a lot of work trying to help people see the value, but it's been really valuable because it also means that those members who do it, when they come into the program, they're there because they want to be there. It's also been successful. We've had about an 80% enrollment rate across our organization as we offer this program, which I think is a testament to how we've framed it and how we bring it in. And the last thing that we established around the program, once we got through our pilot phase, was, this is kind of good for everybody. One approach might have been find those people who are struggling and go after them. And we decided early on that this really needed to be a program for all. And our concept on this was that we want to raise all boats. If you are really competent, we can help you be even more competent. Maybe you're going to share some of that good juju with your colleagues along the way and help us level up the program further so that everyone really wants to be a part of it. So we created this program that started small, but we started by measuring our impact. And we met one-to-one with physicians. We invited them into the program. And then we asked them specifically, well, how did you feel about this program? Did you like it? So we asked them about their satisfaction. Did you feel like it educated you? So we asked them subjectively about their self-assessment for increase in proficiency. And we asked them as well, did it affect the way you view your working day? Did it change the way you see your clinical work? And I'll tell you, Jill, after even a short time, we found such strikingly positive responses to these on pre and post assessments that it wasn't that hard to go back to our organization and say, we think this is a worthwhile investment to grow.
Wow, wonderful. So tell me more about the personalization or the customization component of it. What are you looking at? What metrics are you looking at related to the individual EHR user? And how are you using them to create this personalized coaching program?
I'm glad you asked about that. So let me first mention how the program works, which is fairly simple. It involves really 3 steps. The first is that we need to do a personalized needs assessment. Like we really need to profile the person to understand what they need. The second is a tailored coaching or training session, one-to-one, spending time that fits into their schedule in a way that works for them. And then the third component is really a follow-up where we come back and close the loop, make sure that they know we've been there, what we've talked about. It reminds me of the old adage of first you tell them what you're going to tell them, then you tell them what you just told them. We use that method here as we make sure that we engage. So you raise a great question about how do you support that personalized assessment? And it turns out that there's a lot of available information if you want to create a 360 view of what it looks like for that individual learner. The first thing you can do is you can ask them, and we do. We always survey them before we actually engage them. We ask them about their pain points, what they want to learn, what they're motivated to learn, areas that they want to work on. We then look at their professional profile, and we'd like to know, what specialty are they in? What types of activity do they do? Are they new to practice or are they very seasoned? If we can figure it out, we'd like to know, do they like technology or do they hate it? These kind of things are actually really helpful as we go in to engage. And then we look at their work profile, right? So we look at whether they're full-time or part-time. Are they ambulatory only or they have a mixed practice? Do they work alone or do they have a lot of team support? For instance, a scribe or others that work with them. The next that we do is we do a level of direct observation, or at least we offer that, where we can go in and actually watch them work and observe what it is that they do, how they do it. And that informs our educators that much more about what they might do with the individual. But here's where it kind of gets fun and a little sneaky, is that you can also use the EHR as a way to eavesdrop. And so we've done that in 2 fashions that I think are really cool. One of them is that we can look into the EHR really and just kind of shadow them and see what they do. We can see, is their in-basket overflowing or is it really clean? Are their notes really short or are they really long? Are their notes all hand typed, or are they using macros or dictation or other things that would make their lives easier? So we can actually know a lot about how they use the EHR without even talking to them. But here's one more, which I think is phenomenal. EHRs actually capture all of the activities that the individual does in what is known as the audit trail, which are these metadata, these little captured data that say first they clicked here, then they went to this next function, then they lingered for a little while, then they went back. And that data is very complicated, but is actually can be synthesized and offered back. Our vendor is Epic. They use a tool called Signal, and Signal helps us a great deal to be able to pull out data such as, does the user use certain functions? Do they use them regularly or infrequently? How much time do they spend in one function or another as they're working in the EHR? And the last thing that it helps us to do is to benchmark. We can say, well, it looks like this person spends a lot of time in this function, say chart review prior to a visit, but their peers spend much less. Maybe that's an area that we should focus. So, what it means is that we're really very aware of their needs and their usage and their patterns and their habits. And then when our trainers come in to sit down with them, first they say, what do you want to work on? But almost like in a doctor's visit, when you say, what matters to you most today? In the back of your head, you're thinking, I know your diabetes is out of control. We need to talk about that. Even if you don't know we need to talk about that, we can do the same thing. We can go in and say, I know your inbox is totally out of control. Even if you're telling me you want to work on your notes, I know that we're going to get there. We're going to bring that up, gently bring that into the picture. So it's a tremendous asset for us to be able to have that forensic view. And I'll say that there's a lot of detail available there down to that user level that helps us a great deal in preparing those sessions and making them very high impact as we interact.
Got it. These one-to-one trainers or coaches, who are they?
So these are skilled individuals who've worked really hard to make sure that they understand physician workflows. They're not physicians themselves, but they've worked very closely to make sure that they really understand what these needs are. And they've specifically worked on their coaching methodology as opposed to a didactic methodology. We started with only 2 individuals, but we've grown now to 8 individuals that are working on this across our team. They're guided by physician advisors who we have on our team, who actually make sure that they're working constantly on maturing the program and fitting the program to physician use. So we have medical directors, and then we have our trainers. Not only do they work very hard on the content, but they work very hard on the relationships. We've really worked with our trainers to figure out how to do that and what that relationship looks like. And I'll tell you, one of the most rewarding things for me is when I bump into a doctor in the hall and the doctor says, hey, I had a great session with Parker. He was awesome. When's Parker coming back? Because that to me means that not only have we used our data well, but we've really developed relationships that are valuable and lasting and really rewarding.
That is so true. I'm so glad you made that point because building relationships is key to getting physician buy-in for anything, I think. Are there certain common buckets of deficiencies or inefficiencies that you're seeing in these EHR users and certain buckets of strategies that you're offering to help with that?
There are buckets of use of the EHR that are really commonly challenging. One of them is keeping up with your in basket, and we know that that's a huge dilemma and a huge problem for many users. Interestingly, we found 2 things help in these sessions. One is tips and tricks, like we really help them to redesign how they might engage in the in basket, and we do that in their actual production use of the EHR. So we're not training them in a playground. We're training them right in their real EHR, and we're helping them change their settings and make their shortcuts and build their macros right in the EHR, and then we have them use them and exercise them and get used to them. So we say, okay, we'll build it with you, but then we'll just teach you, okay, now let's do 5 of your in-basket messages, and we'll just get those done while you're here anyway. And you can come away both knowing that you got it done, you're actually 5 messages ahead, you didn't waste your time, and at the same time, we'll help you figure out how to get those faster as you do them. So it's an active practice that we do when we're actually with them. Most clinicians have not spent the time to sit back and say, gee, if I built different columns into my schedule, I could know what's happening before I open up the chart. Or, gee, if I built some quick responses to these common questions, then I wouldn't have to rewrite them each time. But in the midst of working, it's really hard to get that done. So that's a big part of how we do this. And then to get back to the audit log data, we then go back and look and say, let's look pre-post at the audit log data for what we trained about. So, as an example, we work with a clinician on how to do better work in the in basket and how to use these quick responses in the in basket that can make them faster. Then we go back and we look at their audit log and we find out, hey, before they were using these quick responses once a week, now they're using them 10 times a day. We've had big success. Sometimes we think of the audit log data as only useful for outcomes. For instance, are you spending less time on the EHR in aggregate? Or are you spending less time on the EHR in your pajama time in the night? And those are really important, Jill. We look at those as well. We look both in general when we're profiling a physician, and then we also look at those pre-post. But those are tough metrics to move because there's a lot of other things that tend to impact your overall time and how you spend your day. But within these interventions, what we can do is we can look at a process metric. We can say, did you adopt the things we talked about? Or are you shaving off some time per unit of work? So for instance, we can look at how much time do you spend in your in-basket per message? Did we shave off a little bit of that time per message? Because that's where we spend our time really focused with you. And if we have, well, that's a great win. And if we haven't, then we go back as a team and say, what do we think we missed? What could we have done better? What should we do better next time when we're interacting with this physician or another? There's a lot that we can kind of pull out of this audit log data at the individual physician level. There's also ways that we can use the data in aggregate, and that's been very helpful as well. So we can look in aggregate and say, is this department overall doing better than they were before? Or is our organization overall seeing improvement as we do big organization-wide improvement strategies for how we use the EHR?
Got it. Overall, have you seen a difference in either the outcome or the process metrics? And if so, what is the size of that difference?
Yeah, so it's a journey, not a destination. Overall, what we've seen is that we have seen reductions on individual levels in time spent on the EHR. In aggregate, the data is a lot more messy. So it's hard for us to say that the organization as a whole is spending less time because of concierge or because of this coaching, but we can say that we've seen some reductions in time overall, usually through very large enterprise efforts. For instance, restructuring our care teams, job sharing, and how we actually spend the time in the clinical setting makes demonstrable impacts. Using adjuncts like scribes or other technologies that pull off some of that time of documentation. In the coaching program, often we're getting down to the individual level and saying, it looks like you have access to voice recognition, but you've never tried it. Would you be interested to try it? And I think that one of the things I'd highlight is that this coaching is getting down to an execution level. Often we have really great ideas and plans that we hope will work at an enterprise level, but our clinicians and physicians just can't adopt them because they're too busy to look out and find something new. And so we think of this coaching as a really great opportunity to remind them or show them the things that are available to them they may not even realize. Some of our biggest wins have not been rearranging the EHR, but they've just been helping the individual physician to realize that they have other tools available or other support available that they didn't know they had.
Excellent. And are there any other final practical tips or pearls of wisdom that you would want to share with other practice or system leaders who are interested in adopting a similar program?
First of all, I'd say get started, right? Start small and try such an approach. As you do this, you need to measure your impact. Measure is very important. For us, what happened was when we measured the satisfaction, the impact to self-assess proficiency, and the impact to the perceived experience in the workday, those just leapt right off the page and helped us really establish why this was so important and impactful. We've talked a lot about data, and I think having a data-driven 360 view is super important and also really possible. The data that's available to be able to steer such a program is really fantastic and can make it very personalized. And then I guess the other things I would say is to take the long view, like know that it's not just a one and done activity. You want to find a way that you make this a part of what you do over time, and that relationships are really important. Having great people who are really just invested in each other has just been a big part of our success around this. So that when we come and we visit, we knock on the door, it's open for us.
Well said. Thank you so much for joining us today, Dr. Sharp.
Thank you so much, Jill.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.